So the staging is crucial in understanding how to treat the kidney cancer. And in smaller tumors or tumors that are localized to the kidney, the treatment is generally surgery. And that surgery can come in different forms. The removal of the kidney completely is referred to as a radical nephrectomy. Removal of part of the kidney is referred to as a partial nephrectomy. And patients with tumors that are localized to the kidney can also be treated with non-surgical approaches, such as freezing of the tumor with cryotherapy or applying radiofrequency ablation to the area of the tumor. And as I mentioned earlier, there may be some very small kidney lesions that we can simply follow with imaging over time and don't necessarily need to intervene. More advanced lesions within the kidney may still be treated with surgery. However, there's often a team of physicians that may be involved in those type of surgical procedures. Not only the urologist who's removing the kidney, but some patients can actually have tumor, referred to as tumor thrombus, that it can extend up into the major veins and even go into the heart. Under those circumstances, a vascular surgeon or cardiothoracic surgeon may also be involved in the surgery with the urologist. So for tumors that involve the kidney or extend into local lymph nodes, the treatment is generally surgery, and that includes stage 1, 2, and 3 disease. For patients with more advanced disease that have spread outside of the area of the kidney, we generally use a total body type of approach to the management, including drugs, as well as the use of surgery under certain circumstances. The use of surgery in the setting of patients with advanced kidney cancer that's spread outside of the area of the kidney is quite unique. There's actually information to suggest that removing the kidney in the setting of patients who have distant spread of the disease to other parts of the body, for example, lung or bone, can actually lead to an improvement in outcome and survival in those patients. This type of procedure is referred to as a cytoreductive nephrectomy, that is, removal of the kidney in the setting of advanced disease. The management of kidney cancer that has spread outside of the area of the kidney was traditionally managed with therapies that were referred to as immunologic or cytokine-based therapies, with two agents in particular, interferon and interleukin-2. Since 2004, it's been extraordinarily exciting with the development of multiple novel therapies to treat kidney cancer. These particular therapies target specific molecular events that occur within the cancer cell. Kidney cancer is very unique in that it has a very important blood supply. And much like many other tumors, kidney cancer is really the poster child for the development of therapies that target the blood supply of tumors. Although we still consider the use of some of these immunologic or cytokine-based therapies like interferon or interleukin-2, there have been 7 FDA-approved agents for the management of patients with advanced kidney cancer. Several of these drugs, bevacizumab, sunitinib, pazopanib, axitinib, target the blood supply of tumors, and this has led to significant improvements in the outcome and survival of patients with this disease. In addition, there are several agents that target a particular molecular pathway within the cancer cell, referred to as mTOR. These agents are everolimus and temsirolimus, and all of these have now become part of the armamentarium in the management of patients with advanced kidney cancer. Although we don't have a curative therapy for the majority of patients with kidney cancer that has spread outside of the area of the kidney, there are certainly circumstances whereby patients can achieve a cure either through surgery, that is removal of some of these metastatic lesions, and there is a subset of patients that are treated with high-dose interleukin-2 that can also be cured with advanced kidney cancer. The challenges now involve how we use these agents, either together or sequentially, that is one after the other, with the incorporation of other novel therapies to ultimately achieve that elusive goal, which is cure. We may not be able to cure this disease, but with these therapies, we may be able to convert this disease, and I believe we already are, into more of a chronic disease. Like for a patient with diabetes, who may start out with simply problems managing their blood sugar and ultimately may require additional therapies and even develop complications down the road as related to their nerves or their kidneys, or for that matter, heart disease, where a patient may start out by having a heart attack and ultimately end up with the need for medications to support how well their heart pumps. And so I think as we develop additional therapies in this disease and we learn how to better use these therapies, we will continue to drive this disease into more of a chronic illness and hopefully one day achieve the elusive goal of cure. So these drugs have really revolutionized the treatment of advanced kidney cancer. It was clinical trials that actually made this possible, and the participation of patients in these clinical trials that ultimately led to the FDA approval of these drugs, many of which are oral agents, unlike the intravenous or injection type therapies that we had in the past. Although they have different side effects and toxicity as compared to some of the standard therapies that we've used in the past, we as medical oncologists have become more familiar with dealing with these agents and more familiar with understanding the side effect profiles and exactly how to manage them in patients. It's been an extraordinarily exciting time in the management of kidney cancer, and this has become, again, in large part related to the fact that patients have participated in clinical trials that have led to the advances that we see today. Your care team now is typically composed of not only the medical oncologist, but of course the urologist who may be involved in performing a cytoreductive nephrectomy, that is in the setting of advanced disease, and of course additional services as well, such as nursing support and social work services and many other ancillary support services that has made the experience much different for patients today as compared to years ago. There may be a role for radiation therapy as well in your disease in the event that the disease has spread to a particular area that may be causing symptoms, for example bone, for which radiation therapy may be extremely helpful. And so under these circumstances, the radiation oncologist may also become an important member of your care team.